why do organizations, though, allow silos to go on when there's so much at risk?
If your team is putting the budget together for any capital project, it's just a line item you need to put in there to handle those items. So I think a lot of it is ignorance of maybe the holistic approach to taking care of the life cycle of a facility, and understanding that it's our mission to do that. And I've broken down those barriers just by influencing, following up, focusing. I haven't won every battle, but I've won most of the battles. And, continuing to put people in place that support that mission and are collaborative.
Mike just gave you the answer, and it's funny because we've said it all of our careers, and that is we think that the engineers and PDC folks should do a term in facility operations first, because it really is eye-opening. At least spend some time shadowing in those areas.
There's a major crisis facing healthcare facilities management. We have aging employees, aging buildings, and aging infrastructure. We've created the Healthcare Facilities Network, a content network designed specifically to help solve for these three pressing issues in healthcare facilities management. We bring on thought leaders and experts from across healthcare facilities management, all the way from the C-suite to the technician level, because at the end of the day, we're all invested in solving the aging issue. Thanks for tuning in. Look at our videos. You will find that as a theme across our content. This is the Healthcare Facilities Network. I'm your host, Peter Martin.
Very happy to be joined today by my two guests, Dennis Ford and Michael Hatton. And before we get into the topic of conversation for today, I would ask my two guests to introduce themselves, please. Dennis, why don't we start with you?
Yeah, sure. Thanks, Pete. Dennis Ford. I am currently working for Advocate Health based out of Charlotte. We have over 70 acute care facilities, and I'm working in facility management support. I've been in the industry for over 30 years. I've been a member of ASHE for over 30 years. And I did spend a great deal of my career in Texas at multiple facilities. And that's where Mike and I met as we got involved with TAFM, the Texas Association for Facility Management.
How many years have you guys known each other?
Oh, gosh.
Probably, I'd hate to admit, probably 20.
That's probably a good guess.
Since the Texas Children's Days way back when.
That's right.
No, before that even.
Before that, he knew me when I was still in San Antonio.
That's
so
right.
Fun fact, when Michael Hatton was president of TAFM, I was in Houston, and he taps me and says, "Dennis, I need you to be the regional rep for San Antonio." And I said, "Mike, you do know I moved to Houston." He said, "Yes, but you came from San Antonio, and we need to engage that crowd." So I was happy to go back and get some folks together and get them involved in TAFM.
That's right. I'd forgotten about that because that was a really underserved market for the TAFM, and it really helped us grow that member base. Michael Hatton, again,
Yeah.
Mike, Vice President for Facilities Engineering and Construction for Memorial Hermann. And we are in the Houston area and the Houston suburbs. We're the largest not-for-profit in this area, and we've got, I think, about 17 campuses and 280 retail locations, all in what they would call the Houston metro region. And when I started in Houston many, many years ago, it was really a smaller city, maybe the fifth or sixth largest city. And I think we're now number 3, perhaps. So Houston has got massive growing pains, and Memorial Hermann keeps growing with them. So I do everything from problem solving with elevators, which I was working on this morning, versus giant $600 million projects this afternoon. So the whole gamut in between, which keeps me out of trouble. And really, it corresponds a lot to what all of us do in facilities management. We're not as narrowly focused these days as we would have been maybe 20 or 30 years ago. We've become quite the generalist with a few very specific skills as well.
Yeah, that's a good way to put it. You've become quite the generalist. Absolutely. And so what do Mike and Dennis have in common? So Mike is our 2025 ASHE President. Dennis is our 2026 ASHE President. Dennis is incoming, but when this comes out, you will be the president. And I asked both Dennis and Mike to appear because it's always intrigued me, or I've always been interested in, you serve as president for a year, right? You have a year where you're what do they call it? The president to be, and then you're the president, and then you're the past president. So you get that 3-year term, but it's just always, to me, it's always been like, well, how do you accomplish things in that short period of time? And what type of interactions do presidents need to have some continuity and be able to really affect change? And I'm going to talk about some of those things, the future of ASHE, what you guys see as big issues. But what I wanted to start first, Mike, let's start with you, please. As the outgoing president, what accomplishment, what initiative from your tenure over the past year are you most proud of, and why?
Excellent question. I thought quite a bit about it. And when you really look back, I think what I tried to bring the organization back to is, I call it back to the basics with innovation, was my tagline. I mean, we're still talking about conquering the deferred maintenance and infrastructure items. There's still so many dollars to be saved with utilities cost efficiency and things like that. And then also I've spent a lot of time harping on eliminating what our keynote speaker at HCFA this summer mentioned as zombies. At the industry, we do so many things. They call them Sallies and zombies. Do they provide any real value to patient care? Do they really improve safety, or is it just things that we've already done? My favorite phrase is to ask why. So I think if I haven't turned the ship, I've at least got our organization thinking more about those basics of facilities management, especially now in these days of even more pressures on cost control.
Does healthcare as an industry, does it avail itself to that question of asking why? Do you guys find?
I really do not think we do, especially with the whole regulatory environment. A lot of that stuff, we've been doing it the same way for 20 or 30 years, and there's a fear factor involved versus really stepping back and doing more of the evidence-based processes like we may use in a clinical or more of a scientific. But we've been a lot of times we're reactive. The code has always said this, or someone's interpretation of the code. So I think our industry could benefit a lot more from the quality principles that I guess they were really originated over in Japan, with the whole auto industry and such, and ask why and try to work on those lean processes. We talk a good line, but we still debate the same little nuances. And I wonder, do we really bring value to the bottom line of safety or finances?
Dennis, what about you?
Yeah, well, Mr. Hatton has been president. I think ASHE had released the core competency framework, which really is getting back to basics. And I really hope that our audience, takes advantage of the work that was put into that. This industry is so big, and you hear the saying, you've seen one hospital, you've seen one hospital.
Yeah.
and unfortunately, that's true. So, it's something different every day. And I think that's what drives a lot of us, that we enjoy that it's something different every day. And there's different ways and different, strategies for maintenance. And you'll see that across the industry. But there are a few areas that I've really focused on that are just passions for me. One's always been computerized maintenance management system, CMMS. And I think that has now evolved into a term that we call digital twins. And that's springboarding us right into AI, which is a huge topic today. And I feel very strongly that ASHE needs to help us set some national standards, because our business partners, which are wonderful to work with, all have differing opinions and views, I think, on what digital twins are and what we need them for. And I think we need to, take the initiative to define, what are the basics? What is basic information necessary to run a facility? What could be truly automated into or created into an AI agent? What kind of data analytics would we need? So I'm really hoping to at least set some sort of foundation and movement to focus on that from an ASHE perspective. Another passion of mine that's been a passion since day one has been the transition from construction to maintenance. And you hear that Michael Hatton's title, even though he's in charge of facility operations, he lays heavily on the construction side. And And so we have those conversations a lot about, how do you do a good handoff from construction to maintenance? What's needed day one? And I really call that survey ready day one. So can we define that as an industry as well, and have our planning, design, and construction folks embrace that as a requirement, that on day one, this is absolutely what we need to run a facility from an operations and facility maintenance perspective. And then the third item that I've really been passionate and focused on lately, and it really goes back to the comment about when you've seen one hospital, you've seen one hospital. When it comes to emergency operational preparedness, that really should not be true. Can you imagine running 70 hospitals and every single hospital is unique in how we respond to an emergency situation? And having spent time in Houston and actually starting my career in the Panhandle of Florida, I'm very familiar with hurricanes and emergency operational preparedness from that perspective. And so it's an area where when you're in those areas, you have to be 100% prepared. So, are our facility management folks prepared? And if you haven't seen a catastrophic event for the last 10 or 15 years, how many people on your staff have actually experienced it before? And how long can you count on those folks to respond appropriately in the event? And one area that I'm focused on with ASHE is a new handbook that we'll be hopefully releasing within the next 6 months or so, risk management. And a lot of that will be covered in that handbook as well.
Picking back up on Dennis mentioning the, PDC functions versus facilities management, I think one of the probably success stories of my career is that we really do not have that silo. I've broken down that barrier. And as Dennis says, you've really got to take a team approach to that. And I would argue that much of our deferred maintenance and infrastructure challenges that a lot of hospitals or most hospitals face would disappear if we had a contiguous management and philosophy towards taking care of the facility over the life of that facility. It's not just your project, it's the neighboring features that support that project and the utility stream and the roof. I think I've argued about that in some of my columns this year, that we've really got to break down that barrier. And there's so many facilities, as Dennis mentioned, that still have a firm demarcation point that thou shalt not cross. That's really been detrimental to our overall hospital operations. So I really think that's something that we should continue that focus on, and as ASHE grows and ASHE evolves.
2 questions. Number one, Mike, how did you eliminate that? What did you do at Memorial Hermann to eliminate those silos? But number 2, when there's so much on the line to being able to transition effectively, why do organizations, you guys have to interact. You're tied together whether you like it or not. Why do organizations, though, allow silos to go on when there's so much at risk? So 2-part question there, if you guys don't mind.
Wow, we could probably solve world peace if we could do that.
You could, and we wouldn't be able to talk about kind of you guys being ASHE presidents, but you brought it up, and so many people still deal with it, Mike. So what are your thoughts?
Possibly because I started out as a facility manager, and my education and background is I know the facilities, and my first love are the buildings themselves, and I know the features and the systems. And, if you're putting the budget together, if your team is putting the budget together for any capital project, it's just a line item you need to put in there to handle those items. So I think a lot of it is ignorance of maybe the holistic approach to taking care of the life cycle of a facility, and understanding that it's our mission to do that. And I've broken down those barriers just by influencing, following up, focusing. I haven't won every battle, but I've won most of the battles. And, continuing to put people in place that support that mission and are collaborative, whether it be an outside design team or an outside set of project people or internal resources as well. You've got to understand what the problem is. And then I think we just all have to work to build that collaboration, regardless of what your direct reporting structure is. We're also highly matrix these days.
Yeah, Mike just gave you the answer, and it's funny because we've said it all of our careers, and that is we think that the engineers and PDC folks should do a term in facility operations first, because it really is eye-opening. At least spend some time shadowing in those areas. But our key performance indicators are different. Budgets are set by C-suite people, and scopes are typically defined at that level, and infrastructure is not a discussion unless we're inserted into the process. If somebody like Mike Hatton brings us in. But typically, by the time we get to the table from a facility operations perspective, the budgets and the scope have already been set. And what I tell facility operations and facility management folks is you got to understand that you are a threat when you walk in that room, because the project managers are taught and they get certifications on how to manage budget, schedules, and scope. And so the threats that they manage are threats to budget, schedule, and scope. So if you're not at the table from the very beginning, you're coming in to insert something that's going to impact budget, schedule, or scope, or all three. And so you have to be poised enough to understand how to present your case within that structure. So what is the decision-making structure that's been defined? Are we using A3s to put in our information, or an SBAR? And how do we fill that out, and how do we get upper support for the areas that we're focused on? And from an emergency operational preparedness perspective, a lot of it is redundancy in equipment. And so what are the risk areas, and what's the risk if we don't have redundancy in those areas? And can we clearly speak to and define those impacts?
Yeah, but at the end of the day, it's about relationships, and make sure there's relationships between the project management team, who have to put together budgets and scope, and the facilities managers, whatever their title is, and knowing the building and having their list, and making sure you've got the political acumen to work behind the scenes and get those features into the projects, asking what you need, working on the redundancies, as Dennis says. That is the only time to get these things done. And I would suggest if our industry only solved one problem, that would probably be close to the top of the list, because that directly supports the patient care mission, the life cycle of the hospital, and ultimately it also reduces operating expenses if we've got all those deferred maintenance items out of the way as well. So that handles all the items. And I don't want to discount how challenging it can be sometimes at some facilities, but it's a fairly low-tech approach. It's political skill, and it's acumen, and building relationships and working on those behind the scenes. It doesn't happen overnight.
I would just add that facilitation is an art, and I think our teams need to be taught that art, because to Mike's point, if you've been on a highly functioning team, you know that you have, because it does feel different, and it is a lot about the relationships and the facilitation of the requirements and the discussions to ensure that we have alignment across all verticals. Whereas low performing teams, and I've been a part of both, I've been part of teams that they want to cut every dime and nickel they can. And if they cut it, it goes back to the project. So you're told to cut. But yet, if you want to add, there's no money for you, because all you're doing is cutting, right? Whereas the high performing team will say, okay, let's cut here so that we can afford this over here because it makes sense.
Agreed. I think I mentioned that even in my last column with HfN magazine there through ASHE, that we talked quite a bit about that. We've got to break down that barrier. I would argue that's probably one of the basic building blocks of our industry that we have yet to solve.
Well, what I think is interesting is I'm listening to you guys talk about that. And Mike, I think you might have hit this when we talked back in January around like education and educating, both soft skill and technical. And you guys are speaking to, obviously there's a technical component with project management and construction, but you're focusing on those soft skills. And one of the thing, the political acumen, the facilitation, all the stuff you learn. One of the things that concerns me is that with the work from home and with so many folks still not having returned to the office, you kind of lose that informal, like you can pick up a lot watching you guys operate, right? How do you answer a phone call? How do you interact in the office? How do you, like all of that informal learning we're not necessarily capturing it. And as we're hiring people who don't have the experience, we're kind of setting them out there alone without that backbone to succeed, not backbone, without that infrastructure to succeed.
Foundation.
That kind of worries me a little bit, that we've lost that mentorship informally.
Yeah, in fact, we actually are probably growing the silos, aren't we? Because we're isolating people electronically versus forcing some interaction and forcing some of those soft skills that some you learn by seminars and education, others you learn by bad experiences and feedback from peers and mentors and bosses, right? So I think that's a good point. So I think if we don't watch, we're going to just compound those. It's easier to say no if I'm 1,000 miles away on a Zoom or a Teams call, isn't it?
It is.
I can be real horsey if I really don't have to work with Dennis. I can just say no, not in my budget. But you really have to work with that person over the same coffee bar over lunch sometime. You've got to build those relationships.
So
it's
Pete,
really important.
One of the major benefits of belonging to an organization such as ASHE is the networking opportunities. And it's the opportunity to build relationships across the industry with other folks and learning from them and what they do, and having a resource that you can call if you have a question or if you just need another opinion. It's easy for us to do that. Those of us that have been part of ASHE for a long time, I can call Mike and ask him about a project that he's working on and compare it to mine, and vice versa.
And some of those soft skills would probably be a good part of the curriculum for the core competencies as well. I think we focus a lot on the technical items, but I think a lot of those soft skills are something that most organizations had to cut out those types of organizational development sessions from 15 or 20 years ago. But those are so important. As you noticed, Peter, it's just easier to basically build those barriers just by the lack of face-to-face negotiations and discussions.
Yeah. Well, and it's funny that you say that, because so before joining CREF, obviously I was doing the recruiting with Gosselin Martin Associates, and over the past 5 years or so, like, we would work with organizations. They would fire a director because they couldn't communicate. They didn't have the soft skills. You guys know this. It didn't used to be that way, right? If you had maybe 80 technical and 20 soft skill, now that balance, it's at least 50-50. So you need to know the technical because it's what you do. But you can't succeed, and you do, in fact, people do get fired because they don't have that soft skill, because you need to be effective, right? To affect change, you need to be able to communicate. And it's funny, I hadn't thought of it in those terms, Mike, but we are losing people because they don't have that, and yet we continue to cut that form of training.
Yeah, that's usually the first thing cut. And in our organization, we're as guilty as anybody, and it's awful challenging, and it's too easy to do everything with Zoom or Teams as well. So I think that's probably a key point also, that we really got to try to right the ship. And that's probably another direction that ASHE could help us work through as well.
Well, a huge challenge that we have is communicating with the C-suite in general. And that is an area that we do want to focus on with ASHE. So
I kind of want to jump into a little of that ASHE stuff. But before we do, Dennis, you brought this up, and it's interesting to me too. Like the whole CMMS thing, and it's funny, our work is starting to grow in that area, but like CMMS is real simple, right? Okay, you got a CMMS system, I got my work order and PM. So you can think of it kind of in this little silo, but then it's almost like this burgeoning area that goes into digital twinning, that goes into AI, that has all of these tentacles. Like this little CMMS system, it's really the key to almost everything you do. And like, it, but do you find it? So I guess two things, how can ASHE, you talked about the standards, right? Coming up with standards, national standards. That's a great idea. There's nothing there. How would you go about doing that, number one? And then number two, I guess, when you guys, and not to talk badly about, about leadership, but when you guys, when you're trying to articulate to the C-suite the importance of this CMMS system and the importance of data and everything it can potentially do for you if implemented properly, does that messaging get through? That's a lot. I apologize, but you brought it up.
No, I'm glad you asked it, because the short answer is I'm going to help you at the PDC conference in March. So come visit me and watch my presentation.
It's in Houston, right, Mike?
It
It's
is in Houston in March for sure. Yeah, the CMMS for us is the source of truth,
Mm.
and it really begins with an asset inventory. So it's asset management that expands into work order management for sure. And the standards that we have defined have to do with the nomenclature, and it has to do with a simple formula of risk for facilities maintenance and operation is equivalent to the probability that an asset or system will fail times the impact of that. And so there has to be some standardization around how do you manage an asset? How do you categorize an asset? How do you link it to a system? So a parent-child type relationship. What's the probability of failure? Well, that leads into a condition assessment, risk category codes, failure codes. So now you're expanding your CMMS a little bit further related to the asset. But the impact is just as important. So what areas does your asset serve? And we have to be standard from a regulatory perspective as well. So if you're following the FGI guidelines, there are standard names for rooms that are associated with functions, and then those names are associated with regulatory requirements such as ASHRAE 170. So, is it a procedure room? Is it a treatment room? Is it an operating room? Is it central? Is it sterile storage? Is it clean storage? Is it dirty, etc.? So that helps us understand what the regulatory requirements are, and again, what the impact of failure of an asset or system would be in that area. And then from the C-suite perspective, why I'm excited about my presentation at PDC is I'm going to compare the hospital to the human body, and I'm going to tell you that the hospital is our patient, and we need an electronic medical record, which is our CMMS. And if you dive deep into electronic medical records, and Mr. Hatton has had some experience in transitioning to a new system, you'll see that a lot of resources in our facility are tied to that, especially in IT. So if we can start doing some sort of metaphors and comparisons to that, I'm hoping we can get a little bit more traction for the support. And the only way we can get into AI or digital twins is with a good foundation of data. So we have to have a good solid foundation of data. And our leaders are looking at the same thing. They're looking at how do we harness AI to serve our patient population. We're looking at how do we harness AI to serve our patient, which is the building.
That's quite a mouthful there, Dennis.
Yeah, I like that.
I like it. I guess my real challenge, though, is once I get this new system all set up, Dennis, they sell it to somebody else or they stop supporting that database. So I've already invested $2 or $3 million, and then it all changes again. And by the way, it's not compatible with the new version of whatever software backbone it's on. So I guess I'm a little bit of a doubting Thomas that the software industry will help us solve its own problems. But it truly is something that's necessary. I think I would argue that we also need a standardized design drawings that all use the same acronyms and nomenclature, the same condition assessments. We'll get a consultant in who use their own version of a condition assessment acronym. And so before long, I've got 3 different databases that all call an air handler or a chiller or a boiler something different. So it's even more difficult to sort by asset class, especially while you're experiencing this now, Dennis, as your system has grown. You now have 70 hospitals and you were much smaller. The same with us as we acquire somebody is, you're taking a Ford and a Chevy and a Toyota and you're trying to make them all speak the same language. So I think our industry, to be, again, a little bit negative on that, has yet to solve those national standards like you talked. And from what I've known, most of those packages are still pretty much proprietary. So I think that's kind of an impediment to that success that we truly do need.
Do you think it's achievable, maybe not now, but down the road, to come to a national standardization? It would make life much simpler in so many ways. Is that possible?
Not to the extent we'd like to see it. Again, we are all very unique in our maintenance strategies and processes and policies are very unique as well. So again, we're looking at just kind of that basic foundation that you can build on. And again, look at software. I mean, software has basic principles associated with it, but there's always customizations that you can do with your software applications as well.
If you like this video, please like and subscribe to the network. And more importantly, share it with your colleagues in the healthcare industry. Together, we can solve the aging crisis that's impacting all of us.
So, Mike, as president, as former president, as president now, anything that surprised you over your term?
Yeah, I think I did not expect, how challenging it was to learn how to maneuver within a large organization such as ASHE and AHA, and still get it all done with basically you've got 11 months by the time you come on board and then you're winding down. So I think just learning how to do that, especially since I'm a doer in my organization and I get things done and my daily job is to maneuver through the bureaucracies. And I think my biggest challenge was trying to work through and understand how ASHE, what made it tick. And about time you learn what makes it tick, it's time to hand it off to Dennis or the next person as well. So I think that's the one thing I probably felt the most behind the scenes on myself.
That's really interesting. You think, you're a vice president, facilities engineering, PDC, a big, a massive hospital system in Houston. And it's funny when you put it in those terms, like, how to play that game at Memorial Hermann, right? You've been around the block, so you know who to go to, but you step into ASHE. And I guess that's kind of why I want to do this between the two of you is like, how do you affect change when you're dealing with those? You guys come and go, but yet the ASHE group, and this isn't meant as a criticism at all, they work there. You guys come in and then you depart and somebody else comes in. And so that's one of the challenges, I guess, that you have to deal with.
It's probably good and bad, I would say, to make sure that the trajectory of the organization doesn't change that rapidly. But
right. Yep.
Unfortunately, like a lot of the criticisms about some of our, even the senators argue about everything and get nothing done. I think it's got both good and bad to it. So I think learning that, my advice for Dennis going forward is, really put down those 4 or 5 goals that you want to accomplish and try to hammer those home and work on affecting that change. And that's why I spent most of my time probably just on those back to the basics, lower tech, the blocking and tackling that we need in our industry, which leads to the next item. And I think looking back, I had some success on steering the ship in that direction, but I was probably looking for more dramatic change than I could ever affect on an organization of this size.
Do you guys think that is blocking and tackling kind of the basics? Does that message resonate, not just with us, but does that resonate today, or are people minimizing the blocking and tackling that's necessary in favor of kind of the sexy things that are out there, AI, digital, kind of the technologies?
Yeah, I think one of our CFOs used to call it the new bright shiny when we talked about every CEO wants their own nice, bright, shiny hospital versus taking care of what they had. So I think that's very prevalent, especially in the construction business. Everybody wants the $1 billion shiny object versus taking care of the old one. But, the basics that we do, similar to the operations and maintenance as well, is what I would suggest.
So how closely, like behind the scenes, do you, do you guys work together to kind of align priorities and make sure that you're pushing together for the greater good? Does that happen? And how do you do that?
I think a lot of just basically off focus comments and things like that, and email, texting, telephone call once in a while on that stuff. And I think Dennis and I both, I know I tried to work quite a bit on the strategic plan, and we were going down a lot of rabbit trails of trying to solve the world's social problems. And, that really wasn't what ASHE is designed to do. So I think we were pretty effective in trying to get us focused on some tangible future items versus, We're not here to solve world peace. We're not here to solve the social ills. We're healthcare facilities management and PDC people. And how do we get the strategic plan focused back on that? So, Dennis, I think we've had quite a bit of success in that. Not without a lot of pain and discussions, though, I would suggest, across the advisory board.
Yeah, I chose to run for president because Mike got elected, because I had worked with him in Texas before, and I knew we would have a good relationship moving forward. And I also knew the momentum of ASHE. I knew that Skanda was in the window of creating or reevaluating our strategic plan. I knew Mike would be in the window of finalizing and executing the plan, and then I would have the opportunity of carrying that forward. And so it took a lot to get there. It kind of is like herding cats. Because you have a board of many different individuals who have we're all products of our own experiences, and you can't come to the board without bringing your experience. I mean, that's how you got elected there.
Yeah.
And so to Mike's point, there's a lot of different areas that different people want to focus on. And so collectively, because we're pretty grounded in the basics, we're able to at least bring people back to, in our opinion, what the basics are and the core competencies, and start driving home those objectives. And then you got to know that the ASHE staff, the majority of them are actually still fairly new to their positions. There's been a lot of turnover in the past 5 to 7 years in ASHE, and probably only one ASHE member was actually in a facility management position. And so they rely heavily on the advisory board to kind of tell them, what the industry is and what challenges we're facing. And so again, it's up to the president-elect, the president, and the immediate past president to kind of facilitate those discussions and help everybody focus on, what those core competencies are.
Good point. Helps set the vector of where the organization has been and where we want it to go to try to impart some of that influence. Good point about the lack of experience. You're right, at the staff level as well.
Well, it's interesting because you're on the advisory board, like you gentlemen and the people on the advisory board, like you're used to having some control, right? You're used to taking charge. I mean, you have egos. You have to have an ego to do it well. But then you go to these boards and everybody's kind of like you, right? But you're used to having that control. You're used to running a hospital. You're used to running a department. You're used to telling people to do things and listening and collaborating. But it's a whole group of that. So it's got to be pretty difficult.
It's not just our personal experiences in the workforce. Honestly, Pete, it's our experiences within the state-affiliated chapters. Where we're typically board members of our state chapters, we become presidents of our state chapters, and we do have full authority to make things happen. It is different being an advisory board versus being an actual board of directors. And that is a hard transition for some people that join, and that is a challenge. And so in January, I'll be meeting with the new board members, and Mike did it this past January. And part of our discussion is, hey, this is not like your state affiliated board. This is a little different. Let me go ahead and give you some history so that we don't have to have those discussions again.
That's a good point. It's just so totally different from the large state organizations, especially those that are more successful, like the ones that Dennis and I both came from, where you've got full governance and full profit and loss and visibility and set the program. It's in some regard, I guess there's a lot more autonomy, and it's just probably 180 degrees different from the advisory board function. And that's challenging to get used to, especially if you're a take charge kind of person like we all are. That's why we're there.
Right. That's why you're good at what you do. Yeah, I was thinking as you were talking, like, do you think that, it's an interesting dance, I guess, right? You got the national level, you got ASHE, but you guys were talking about kind of the local chapters. I was just down at the FIA conference in November. I've been to TAFM. I've been to enough of them. Like the local chapters do it really well. I mean, I think they've really kind of advanced. The education is there. The the vendors, I think there's a huge uptick on the local level, and it's sometimes easier for people just to get to the local as opposed to the national. How do you balance that? Because you need the state chapters because that's where most people go, but then you also have the national level. I don't know if that's an actual question, but how do you balance those competing needs?
It's definitely been a focus for us, and I'll let Mike speak to it more pointedly, but we do need to ensure that we have good relationships between ASHE and the state chapters, because to your point, most of the people will have a better opportunity to attend a state chapter, and the state chapters do have the opportunity to bring in ASHE type training and presentations as well, and so we definitely want to ensure that that's a strong relationship.
I think that's probably one of the other key points is how do we take ASHE to the chapters versus the chapters to ASHE, given the financial constraints, especially that was evident the year before last when it was in Anaheim, California, a fabulous venue, but expensive and difficult for a lot of people to travel to. So, ASHE's got some great, what I call boot camp programs or basic education. They're typically in Chicago or Indianapolis or Nashville. And we've talked quite a bit at the advisory board level about how do we get that out to where the major medical centers are and have ASHE reach the people versus having to have the travel expenses and fill up our future pipeline that way. Are the days of always having a big annual conference like the Healthcare Facilities Innovation Conference, is that always going to be with us, or is that ultimately going to become too expensive? And as you mentioned, Pete, as I've seen that myself, as I traveled around, there's a lot of great content and the same basic speakers at a lot of the state chapters. And I know ASHE is starting to put together some of the regional conferences as well. For the first time this year, they've had, I think, 3 of those this year. But what is the future of the organization, and how do we keep that brand strong and push it out for the next generation, especially those that live on this versus, live on your iPhone versus actually that's how they get their education these days. Yeah. So we're at those crossroads.
No, I mean, there's big questions out there. The nature of how people get information, how they learn. Listen, I love face-to-face. I love going to the innovation conference because I love to see people. It's an opportunity just to connect. But not everybody feels that way these days. So how do you evolve and change and still stay relevant?
Yeah, there's a lot of opportunities for ASHE that we are focused on and do align with our strategic vision. One is revamping our website, getting all the tools aligned, make it easier to navigate and get the resources that you need. There is a focus on virtual type training opportunities that we can put together so that people don't have to go to a conference. And then, as Mike mentioned, we are looking at regional conferences as well. But I will tell you, Pete, one of the biggest challenges that I've seen, and I've seen it at the state level as well, is how do we get the front line worker to a conference where they would benefit from maybe some hands-on training and networking. That's been a challenge, even at the state level.
Yeah, I think that's going to continue to be a challenge as finances get tighter, and hence my comment is how do we get ASHE out to where the big concentrations of hospitals are? And there's probably a dozen major regions in the U.S. that has those concentrations that we can take ASHE out there and make it affordable and make it more day sessions versus having to spend 3 or 4 days at a conference. So I think that's an excellent point Dennis brings up about that's how we grow the pipeline for that next generation. Let's face it.
I think, Pete, just to give an example, it was in Arizona, and I can't remember which organization because I believe they do have a couple affiliated chapters there. But they sent a shuttle out to the local hospitals to pick up some of the technicians and bring them to the conference. And I think they were only staying for maybe half a day, right? So just bring them in for a couple concentrated sessions and then take them back to the hospital. But it's things like that first off, we need to know that are happening. We need to know lessons learned, and then we need to see if there's a way that we can do that from a regional perspective.
Yeah, it's funny you mentioned that, Dennis. I was talking, I think it was Joe Taylor from Kentucky, and I think he was telling me that the Kentucky engineers did that, right? That
Well,
they had a bus
took
from
a bus
Louisville
to the annual conference.
That was it, to the annual.
Yeah.
Yes.
Yeah, they said, who wants a ride? We're going to take a bus and you can ride with us.
What a
That's
novel
great
concept that both grow ASHE and the state chapter, right? And they had 2 or 3 hours worth of face-to-face time on a nice bus as well, and they solved some transportation problems, so they reduced costs. So I think we really need to be, that's truly what I would suggest is both back to the basics and innovative, is how do we get our pipeline, those at Dennis's, station and career, and my as well. We can always get to the conferences and the education. How do we get that future manager or that team leader there that ultimately will become the chapter leaders and grow into even the executive ranks as well?
Well, as you guys were talking about that, I was thinking like bringing ASHE to the chapters. I like that distinction there, and talking about the regional events. Like, we know that we have a problem bringing folks in, like those critical access hospitals that are in the middle of nowhere. Those folks cannot get away, and a lot of the times it's not right, but they're not necessarily. They feel like they're forgotten, right? They're kind of left behind, and that might be a way, the regionalization to hopefully allow them to get some type of an education, because it's almost impossible for people in those hospitals to get away because they're wearing thousands of hats.
Right.
We have to try every thing that we can. And the other thing we're looking at is the fact that we are aligned with the American Hospital Association. We're a professional membership group, and they do have a conference for rural hospitals. And to your point, at a rural hospital, you wear multiple hats. So the administrator could also be the facility manager at a facility like that. So we're hoping to get opportunities in front of these groups to share the fact that we do have resources available, and maybe those are opportunities for the virtual training, because to your point, that the guy that's doing 50 different things is probably not going to be able to leave the hospital.
Yeah. No, I remember we doing a recruitment for Catholic Health Initiatives before they became Common Spirit, and they had 3 critical access hospitals up in North Dakota that were kind of on a triangle, and one was, and just talking to those folks about the challenges of running it. You're running to the Home Depot, right? If you have to go to Home Depot, that's where you're going, and it's different than any other experience. So we can't forget them. This hour has really flown by, but I want to stay to our time. When you guys think about the next decade, and you've touched on a lot, where do you see the profession going now? A decade's probably too far because a lot can change, but where do you see this profession heading?
Well, I think AI is something we have to embrace. We just have to know that the industry as a whole is talking about it. Healthcare as a whole. How do we embrace AI? How do we embrace robotics? How do we streamline operations? How do we streamline costs? These are all focuses, and we just need to be in front of it and not behind it. And I do see that as a huge change. One of our biggest challenges is the fact that our folks that have the institutional knowledge are of retirement age, and the new generation is not looking to start a career in healthcare facilities management. And so how do we get the word out that this is a career worth doing? How do we educate those folks when we do attract them? And how do we make it attractive to them? And if this new generation is attached to their phone, if they're attached to short video clips, then how do we embrace that and make it meaningful for them?
I guess I would add to that, but we also have to make sure that we're getting rid of the zombies and killing off the Sallys that we learned about at the HCFA this year. If we just hardwire those and code those and use AI to make it easier to find bad best practices, then is that really going to help our industry? So I think we need a parallel pack to quickly break down those silos with PDC and make sure it is a holistic approach to the life of the facility. Get rid of the Sallys, the zombies, the things that we've done every day that provide zero value, and really work from an advocacy point of view and get rid of some of those regulations and use the power of ASHE and the AHA to really influence some of those.
So with that said, a huge impact that ASHE can make is to advocate CMS to adopt a more recent standard. We're still under the 2012 Life Safety Code, and there have been a lot of changes, and a huge value of ASHE is not just the networking, but it's the advocacy, and that's why we need to support ASHE. And we hope that ASHE is advocating for exactly what Mike is saying. How do we reduce the regulatory burden so that we can reduce the cost of healthcare? And how do we motivate CMS to adopt a standard that would give us a little bit more leniency in that area and be able to focus on the areas that need our attention?
Yeah, I'd really hate to invest in hardwiring a computerized maintenance management system or digital twin that's codifying all the zombies that we've done in the past life. We surely should adopt technology looking forward and really evidence-based design, failure mode analysis. ASHE's done a lot of work on it. It really hasn't been universally adopted, the whole failure mode analysis and the things that Dave's working on and some of the folks at Kaiser as well to really work on the why. I would call that the digital why. If it's statistically not improving outcomes, then why are we dealing with it still? And that's, to me, is what the biggest focus of advocacy is, getting rid of items, not just coming up with new items.
I thought her presentation, and if I'd known you were going to bring her up, I would have checked on her name. I can't recall the keynote, but it was fantastic.
Yeah, Diane Candler, I think her name was. And
that was it. Yeah.
I was so impressed with the message, was so spot on and really parallel with what I was doing is, let's try to drive some of these items that are insane, like the everyday check exit lights once a month. I think ASHE has got a lot of that work and CMS is working on it, but that's still not totally out of the code. There's a lot of good work towards that, but I can think of a dozen things just like that waste time and cost money with zero outcomes to improve safety or the bottom line. And yeah, her message was so spot on with those items. That's why I spent a lot of time pondering that. And really, we should spend another hour just talking about those zombies and just kind of rapid fire them out there. Would be kind of a good session in the future.
Actually, I should bring her on. We could do it with her.
She would be great. Yes.
That would be great.
Actually, I'm doing okay. Can I ask you one last thing? I know you got to go. You probably have meetings. How far along do you gentlemen think we are? And you don't have to go into a lot of detail, but kind of on that AI technology journey that you've been talking about. Where are we in the cycle of AI in healthcare? Are we just at the tip, 5-10%? Like, where are we on that journey? Because you're right, Dennis. I mean, you're hearing the beginning of the year, we heard AI, but now it's seemingly everywhere. Where are we on the journey?
Well, I think we're trying to establish standards. HIPAA is very important to us. So how do you incorporate AI without sharing information that you shouldn't? We've even had examples in presentations that we've done and seen. You don't want floor plans of your facility floating out there. So how do we protect the database that is being searched from AI? How do we ensure that that's good quality data? And I'm sure that's what our healthcare leaders are thinking about as well. But I would tell you, we're definitely behind the curve, especially facilities, because Pete, we still have facilities out there that don't even have a good asset inventory, that are not using a CMMS system, that don't have standardized nomenclature. And these are the basics. And we've got to really get everybody to that foundational level so that we can start building upon it and being able to ensure, again, that decisions are made on good quality data.
I guess I would suggest that we're probably going to be on the shirt tails, though, of the electronic medical record and as that evolves and the AI technology and the clinical side. But that's actually a good thing. Yeah. We can learn from them. And if one day we did share a common platform, wouldn't that be so fabulous? I know we're still trying to modernize. We did Epic last year, and now we're next is the whole, overall AI and basically optimization of the whole work process flow here at Memorial Hermann, like a lot of facilities are. But that's yet another software platform. So I think one of these days we will get there. But I think it's evolving much more quickly than our bricks and mortars functions have been in the past.
Absolutely. Absolutely. Well, my thanks to Michael Hatton, 2025 ASHE President, Vice President, Memorial Hermann, Dennis Ford, 2026 ASHE President, Advocate Health, Corporate Facilities Management. I got it right. Advocate Health. So
You got it.
Dennis, Mike, thank you so much for your time today. Really appreciate it. Great discussion. We'll come back if you guys are willing. I'll reach out to Diana. That would be a great episode of getting rid of the zombies for healthcare. Talk about saving time, right?
Wow. And
Absolutely.
bottom line, and it's so appropriate to what we do every day, the zombies. So thank you,
Absolutely.
Pete, for putting this together and for what you do.
Absolutely.
Oh, my pleasure. Thank
Dennis,
you, gentlemen.
Dennis, good luck as I hand off the baton as well.
Well, thank you, Mike. You left me with a good foundation, buddy.
Thank you, guys. Bye-bye.
Thank you, gentlemen. Thank you
Thanks,
for
Pete.
watching the Healthcare Facilities Network. We will be back with a future episode. Have a great day.
If you want to be a guest on a future episode of the Healthcare Facilities Network, go to healthcarefacilitiesnetwork.com and let us know who you are and what you want to talk about, because together we can solve this critical aging issue.